It's estimated more than 500 million people around the world have had COVID, and millions of them could still be suffering with long COVID. Health and Human Services has been in the forefront of trying to better understand and treat the numerous insidious side effects of COVID. Today, we have an important update. Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. It is Thursday, March the 30th. Jessica Lovell is standing by to take your questions. I asked Jessica if I could host today because I'm so excited about our distinguished national guest with us in the Dolph Simons Jr. Family Broadcast Studio, along with the update we're about to share with you. We welcome Admiral Rachel Levine, who serves as a 17th Assistant Secretary for Health for the U.S. Department of Health and Human Services. The Admiral is also a pediatrician with insight into what we're learning about the effects of COVID on children as well as adults. Admiral Levine, people often question if their symptoms of long COVID are real because some of the more common complaints of fatigue, brain fog, headaches, stomach pain, fever, mood changes can be parts of other illnesses as well. So, have we determined, is long COVID real?
Well, good morning, Dr. Stites. Thank you so much for that question. Yes, we have determined that long COVID is real. But long COVID might not be one thing. With really interesting research from the NIH, it might be some overlapping different syndromes that are due to COVID-19 that might have different etiologies, different causes, and perhaps different treatments.
So SARS-CoV-2 is a tricky virus, isn't it? Do you consider long COVID a public health crisis?
Well, certainly COVID-19 has been the biggest public health crisis that we have seen in over 100 years, and it has been extremely challenging both for the United States and globally. One of the consequences of the COVID-19 pandemic is long COVID, and so we are working really, really hard to address this issue.
You know, I'm still stunned that there are people who are doubters out there, and all I can say is there was a time when we had 250 COVID patients here in our hospital. I guarantee you this is real. So is long COVID. We have a lot of patients like that. So HHS has aggressively been working to address long COVID. Give us some of the examples of what things are going on.
Well, right now we are really taking a whole of department approach and a whole of government approach to long COVID. So under the President's order in April of 22, in August we released two reports. One was on supports and services for long COVID, and the other was the National Research Action Plan on long COVID. And this involves research at the NIH, research at the CDC, and some very interesting research at the VA as well. We're also devising supports for people with long COVID with academic medical centers and working with primary care physicians as well.
You know, we mentioned at the top of our program, you're a pediatrician. Is the research showing any surprises about long COVID in children?
Well, no surprises, but we have found that children do have long COVID, particularly teenagers, but also younger children as well. And they have some of the same signs and symptoms that we might see in adults, but others that might be particularly to adolescents, particularly changes in blood pressure that we might see. So that research is ongoing at the NIH.
You know, HHS has been working closely with the NIH and their RECOVER study. Now, for our regular viewers, you are familiar with this study, as we've talked about it many times before, and many of you may have joined in the research which started back in 2021. In February of this year, that research was showing potential disparities amongst racial and ethnic groups. The study found that individuals of different racial groups had differing rates of symptoms or conditions that are associated with the syndrome of long COVID. For example, Black and Hispanic patients were more likely to experience conditions associated with the circulatory or endocrine system compared to white adults. Additionally, Black and Hispanic adults were more likely than white adults to experience any condition associated with long COVID. Admiral, what does this tell us?
Well, we know that health disparities have existed in the United States, and COVID-19 has shown us the depth and breadth of these health disparities, and that includes long COVID. So actually, way back in 2021, under the President's commission in terms of health equity with long COVID, one of the lessons and one of the recommendations from this committee was to research long COVID, particularly with that health equity lens, looking at African American communities and Hispanic communities. The NIH is really working hard to have a diverse patient population that they're looking at with long COVID. In fact, Secretary Becerra of HHS has been emphasizing that all along. It's one of his top priorities, and the NIH is working towards that.
So what is HHS doing? You've mentioned a few things. Are there other things HHS is doing to help overcome some of these challenges?
Well, so again, there's research from the Recover Project. There's research from the CDC in terms of their Inspire project, looking at the epidemiology of long COVID. And then some really interesting research from the VA. Of course, the VA has an integrated health system and an integrated medical record, and they're able to mine that medical record for data about patients in the VA system that have long COVID, and have come up with some very interesting results. Actually, in the last month, they identified specific neurological symptoms that patients with long COVID might have, so certain neuropathies. But again, we need to work on the systems and supports for patients with long COVID. ARC, one of the HHS divisions, have money to develop hub and spoke models with academic medical centers, and HRSA is looking to train primary care providers.
All right, so a report from the National Vital Statistics System identified that American Indian or Alaskan Native individuals had higher rates of death due to long COVID than non-Hispanic white folks. There are also differences in long COVID outcome based on gender, socioeconomic status, and where someone lives. What are we learning from all this?
Well, we are collating and collecting all of that data to find out the significance of that. Certainly, long COVID might be more common in certain groups, such as African Americans, Hispanics, and you talked about the American Indian, perhaps Native Alaskan community. And so we need to learn more about all those different aspects of long COVID, those epidemiological issues, as well as the pathophysiology and why certain groups have long COVID, different types of clusters that we might see, and then work to develop treatments.
All right, so Edward Levine, there's another study of diagnostic codes that revealed even some other patterns. Of nearly 24,000 patients, records studied showed common clusters of conditions like neurological, gastrointestinal, and cardiopulmonary conditions, coming heart, gut, etc. What does the identification of these clusters mean for long COVID research and clinical care?
Well, they're critically important, and this comes out of research from the Recover Project about these clusters, and I was referring to that. And there might not be one cause. The cause of one cluster might be somewhat different than the cause of another cluster in a different organ system. And so that's what we're trying to learn through the really expansive Recover Project, and then we can develop specific targeted treatments for patients in those different clusters with specific symptoms.
You know, it feels like long COVID is this big black box. And when we can't really give you a diagnosis, we call it a syndrome. And that gives us the ability to lump a lot of stuff into it. And it feels like right now we've lumped a lot of things into long COVID. It also feels like what you're discovering is that really there's different parts to this. And in some ways, there are differing complications of having had COVID-19.
Well, that's exactly correct. For example, some patients have had significant cardiovascular complications. They have had problems with what we call as neuromediated hypotension, is that they tend to faint when they stand up, and postural tachycardia, that their heart rate goes up. Others have had myocarditis. Others, for example, we mentioned children have had MIS-C, multi-system inflammatory disorder associated with COVID, which can have cardiac conditions. That might be very different than the people who have had lung and pulmonary complications and the challenges that they have had. And so we need to find out more about those different clusters, more about why people are having these different signs and symptoms in those clusters, and then develop targeted treatments for those specific patients.
Yeah, because they're really not one disease. There's really multiple diseases under this topic. So it's going to have different types of therapy. So talk to me a little bit. Some of the neurological changes that people had, they're having these sensory changes that can be a little odd. Talk to us a little bit about some of that.
Well, we knew from the beginning that patients with COVID-19 often had sensory problems, particularly with smell and taste. So we have known that actually since the spring of 2020. Most of those patients get better, but some of the patients have had continued problems with smell and taste. Other patients have had other neurosensory problems. Senator Kaine from Virginia, who's a big advocate for long COVID and has sponsored long COVID bills for funding, has had a peripheral neuropathy in terms of the neurological sensations in his legs, and he has spoken out about that. And I've had the opportunity actually to be with him talking with patients with long COVID about their different signs and symptoms. So also fatigue is a very common symptom which has a neurological basis. So it's very complex, but we are working to tease that out.
You know, you mentioned about listening to patients, and Admiral, we know that you believe strongly in hearing from long COVID patients, and we wanted to hear from two of our patients who are healthy, active young women before COVID.
Terry Allen and Michaela Dreyer have never met, but they share something big in common that they wish they didn't.
I was 29 years old and I had no pre-existing conditions. I'd never needed medication for my body.
I was tip-top, super healthy person.
Both Kansas City women were among the first wave of Americans to catch COVID in March of 2020. And almost 2 years later, they're still sick.
I worked out in the pool twice, but I'm so fatigued after, like days of sleep. I usually will sleep 2 or 3 days.
And both Terry and Michaela have been diagnosed with a post-viral central nervous system disorder called postural orthostatic tachycardia syndrome, commonly called POTS. Among the symptoms, debilitating weakness and frightening heart pounding. Terry had an episode during one of our interviews and had to call 911.
Hold on, my heart rate's going up. Can I pause this for a minute?
Another thing they both have in common, neither woman ever dreamed something like this could happen to her.
I didn't have any pre-existing conditions. I didn't have any reason for my blood pressure to be skyrocketing. I didn't have any reason for my heart rate to be out of control.
Yet here they are, still fighting tooth and nail to get back to the healthy lives they enjoyed before the virus.
There's the line that you double tap if you feel something.
Wondering when that day will come.
You know, my daughter had POTS syndrome. It's hard. How common is that?
Well, POTS syndrome is not new. In fact, in my pediatric and adolescent medicine practice at Penn State, I saw many adolescent young women with postural tachycardia syndrome, chronic fatigue symptoms, and it seemed to be after a virus. So this is actually quite common, and now we're seeing it more and more among patients who suffer from long COVID.
Yeah, I mean, this is a pretty difficult and devastating illness because it can really affect you. You heard that one patient say, I can't get up and exercise anymore. I've only been in the pool twice. This is someone who clearly was a advocate for exercise. Any hope as far as therapy for POTS?
Well, you know, there have been treatments for POTS, again, before we were researching long COVID, but not a cure. But we did have medications to try to help people with their signs and symptoms. And also, we found that, that certain types of physical therapy could be helpful, certain medications could be helpful, cognitive behavioral therapy can be helpful because it's a mind-body connection illness. That certainly doesn't mean you're making it up. It means that it has to do with your neurological system, which is part of your brain. So it all fits together. That is true for patients who suffer from long COVID as well. There is a mind-body connection in terms of this, such as the neurological symptoms that we were mentioning. So there's always hope, and there's more and more research coming.
So what's your sense? What are you seeing in the data? Are people eventually recovering, or is there a subset of patients that it doesn't look like recovery is coming?
Well, Dr. Stites, we're seeing both. So that we are seeing that the majority of patients over 6 to 12 months are making a recovery, but we are seeing a subset of patients that are having chronic long-term symptoms that are really disabling, as we heard from the young women today.
You know, so full confession, and our listening audience knows that I had COVID back late last winter for the first time. Fully vaccinated, did all the right things, but you know, it's out there. It's a very highly communicable disease, and wasn't terribly sick, but that exhaustion, that fatigue lasted for 3 months. These things are real. So,
Dr. Stites, these things are real. So if there's any message that people should take, it's that long COVID is real, that at HHS and the Biden administration, we're doing everything we can to learn more about it through these studies that we were talking about, particularly the RECOVER study at the NIH, and we're developing programs and supports for people who have long COVID and try to get them the help that they need.
We know you have questions, so make sure you send those in to us on YouTube, Facebook, the Medical News Network, and you can find the links right here on our screen. We're going to turn to Dr. Dana Hawkinson, Medical Director, Infection Prevention and Control. I call him Doc Hawk or Hawkeye. But first, Hawkeye, reflect on this long COVID.
Yeah.
You see a lot of long COVID too.
Yeah, we get referrals all the time in our infectious disease practice for long COVID. Unfortunately, we only see really people with acute infections, whether that's COVID or whatever that acute infection might be. We certainly do refer those patients on to whatever subspecialty they are having problems with. For example, if they are having chronic headaches, it's probably neurology. If they're having chronic cough and shortness of breath, it's referral to Leslie Spikes, who's helping lead the pulmonology group in their efforts to tackle this problem. If it's just fatigue, it's typically internal medicine or physical medicine and rehab. So we try to refer them to those subspecialties. And if you remember, we had our virtual long COVID clinic because we identified and recognized how significant of a problem that was for many people, even those people who were otherwise very healthy and young. And we know it's a problem, but that virtual clinic became overwhelmed. And so right now it is just continuing to funnel and track those people into those specific subspecialties for which they may be having the problem.
Yeah, before the COVID count, just one moment, reflect on that a little bit, if you will.
Yeah.
This long COVID clinic, it feels like this is a disease that every primary care provider has to be not only familiar with, but skilled in now, because it's everywhere.
So I agree with you, Dr. Stites. It's really important that we have both, that we have academic medical centers like at KU to have the hubs and to have specialty clinics to deal with very, very severe cases. But it is very important that primary care physicians and other medical providers be educated about long COVID. And so there is money right now for ARC, which is one of the divisions at HHS, to set up these type of academic medicine centers of excellence. And there's also money in the President's 24 budget for HRSA to educate primary care providers about long COVID so that they can treat the majority of the patients.
I think that makes complete sense. And then fortunately, we were able at least to have some specialists in every group and say, okay, I'm going to focus on this long COVID thing, but I do think primary care physicians have to be highly skilled because so much of this is a watchful waiting at this time still, I think.
Yeah.
Okay, Hawkeye, COVID count.
Yeah, COVID count. Well, right now in the health system, we have 45 total cases. 27 are active. You know, Steve, earlier in the week we did, I think, get down to like 21 or 22 active cases, which I was happy about. We've kind of gone up now, 27 active, 4 in the ICU and 1 on the ventilator.
You know, just to reflect too, about a year ago at this time, we had a lower number than this. I mean, I do remember back last spring, we got down to 5 or 6 patients in the hospital.
Yeah.
So we clearly have more, and you kind of see that happening nationally. You watch the CDC data pretty closely, and it just is kind of hanging out on this plateau at the moment.
Yeah.
And what I hope is it's going to trend down. But Admiral, it hasn't gone down as much this spring as it did last year.
Well, you know, it hasn't. We're still dealing with Omicron and various variations of Omicron, which, as you mentioned, is a very, very contagious illness. So we are seeing this consistent plateau of cases, but certainly we feel that the public health emergency is ending, and so officially in the federal government, the public health emergency will end in May. But all of our work at HHS is going to continue. The work that we're doing through NIH and CDC, the work that we're doing in my office and with the Surgeon General and with preparedness, all of that work will continue in terms of this longer phase as the public health emergency ends. But we're still on it very carefully.
Yeah, thank goodness, because it's still out there. There may not be a COVID health crisis, but there's a COVID health crunch that's still going on right now.
I understand.
Hey, so there was a study published in the journal Nutrients. Yeah. It looked at curcumin, the chemical in the spice turmeric. Yeah. It asked, does it impact inflammation in post-COVID patients? Now, listen, I've been in medicine approximately a very long time. Yeah. Curcumin is not new. Obviously, it's not if it's part of turmeric. But as far as anti-inflammation, it's been around for a while. I remember we used to use it in lupus. We used to use it in scleroderma, all sorts of. Well, compared to placebo in vaccinated people, it appeared to lower certain inflammatory biomarkers like IL-6 and MCP1. Okay, Hawk, what's this mean?
You know, this was a very small study published in a lesser-known journal. I mean, certainly we've talked about different journals, but it was a very small study. I think 15 people in one arm and 16 people in the other arm. Some of those, you know, one arm got the turmeric compound that they were giving, one got placebo. And what this showed was that after infection, they looked at 10 or 12 different inflammatory markers, and 1 or 2 of them had been decreased. I think it's a good stepping stone, but it's really unclear what this truly means in clinical day-to-day life. But I think it is one good step towards trying to find other methods. You know, we are always asked, Steve, how can I get my immune system good, and how can I stay healthy, and do I need those immune boosters? I don't believe there's any data to support the fact that those immune boosters you buy over the counter at the pharmacies really help anything. This may be one step towards looking at that, but also with this study, they really were checking people while they were on the supplement. And at 4 weeks, they recheck them, and then after they stop. So it's unclear how this really affects the person's clinical day-to-day life, but it is one good step towards looking at something to help immune function moving forward, probably not just for SARS-CoV-2, but for other things, just as you said, anti-inflammatory effects. One good step, but I wouldn't base any medical practice on just asking people to increase their turmeric uptake.
Yeah, no, I probably wouldn't either. And Admiral, you and I don't know, I'm pretty old here in the studio, maybe the oldest person, but you may have been around sort of the same time when curcumin was kind of this new thing that we use for a lot of rheumatologic disorders.
Well, so as you all were saying, I mean, this is an interesting but very small study and could form the basis for further research, but certainly nothing that we would do for clinical care. And that is the importance of the RECOVER project, is that we have seen a lot of very small clinical trials of different types of medicines about long COVID, but nothing that had the statistical power to really influence clinical care. But the research coming out of the RECOVER project does. And the RECOVER project is not one study. It's actually a collection of 6 different studies. But one of the biggest one is this longitudinal study, prospective study, looking at COVID and then people who have had long COVID and looking at all the factors that we've been talking about. And so the NIH will be doing clinical trials starting later this year with enough power to really inform clinical practice. The one thing I do want to say is that there is one thing that we're really much more confident about that can prevent long COVID if you get COVID, and that is that you have been immunized and boosted and updated. Is that if you've been immunized, boosted, and updated, you have a much lesser chance of getting long COVID. So the one thing that people can do is to make sure that they have their immunizations and their boosters and their updates.
You think it's going to change if we're going to stay with once-a-year boosters now?
We're still looking at that, and the FDA and the CDC are looking at that very closely. So it's premature for me to have any comment, but it's one of the things we're looking at.
Yeah. I try to get a little bit out there. All right. Jessica, do we have any questions from reporters or from the community today?
We do have some good questions from the community, and a comment out of the gate from Georgianne. Just amazing to have Admiral Levine on as a guest on the program today. Just really appreciates the COVID update and information. Joellen wants to know, she says, could you discuss fatigue being neurological? She says, I've never really understood that. What do we know about that?
Yeah, that's an interesting comment because we forget that it's our brain as much as anything that has to rest at night. And when we're fatigued and tired, a lot of it is central nervous.
That's exactly right. So when I say it's neurological, I'm talking about the central nervous system. Of course, we have the central nervous system and we have the peripheral nervous system in our arms and legs, etc. We also have our voluntary nervous system, raise your arm, and then we have the involuntary nervous system, sometimes called the autonomic nervous system. And it really seems that these autonomic nervous system symptoms can be triggered by many different viruses in terms of COVID-19, and that's what I mean in terms of fatigue, imbalances in your autonomic nervous system, as well as leading to the POTS that you were talking about.
You know, it is interesting. We spend so much time in medicine focusing on what's happening to us while we're up and about. Yeah. But we spend a third of our lives, or we should about some of that time, some of us may not quite that much, I probably don't get to hit that target, but asleep and in bed. And how our brain works at night when we're asleep is remarkable. Because it just changes how it works. It shuts down other parts activate and are hyperactive at night. It's fascinating. I think I've seen something that said part of the problem with long COVID and fatigue is that our brain recovery cycle doesn't work right.
Well, that's one of the research projects that's being part of Recover. So we're looking at many different aspects, many different organ systems, including of course, the nervous system, but also the lungs, the heart, all kind of fits together. Your mind and your body are connected. And there seem to be these disturbances caused by COVID-19 that can lead to the symptoms of long COVID.
So, Jess, other questions?
So, Admiral Levine, Jeremy wants to know, at a national level, are there any key lessons learned that we will use in the future if there are ever any potential future outbreaks or other viruses?
Well, I think that we do have to learn the lessons of COVID-19. I think one of the lessons is the importance of public health and the importance of local, state, and federal public health officials working together. In that, I think that has worked really well in the last couple of years. In the first year of the pandemic, it was a little bit more of a strain, but I think that we've gotten into our groove and we're working much closer together. I also think that we need to be prepared. We need to have the personal protective equipment necessary. We have to have the national stockpile, available and be prepared for something like this type of pandemic. I also think it highlights the importance of accurate scientific information and the communication of that scientific information by local, state, and public health officials working really closely with expert physicians like you have at KU to make sure that we educate the public about about the science and what we can do to prevent and then to treat something like COVID-19.
Jess.
Admiral, Lon has a question and comment. It's been 3 years for some of these long COVID sufferers. Does that make long COVID a chronic condition, a forever condition, in your opinion?
Well, I think it is a chronic condition. We don't know if it's a forever condition. So we do not know that. Again, the most symptoms of long COVID people would have would be about 3 years now, but we don't know if those symptoms will continue. And also, as I mentioned, the NIH is going to be hopefully starting clinical trials this year on specific treatments for people with long COVID to try to help them with their symptoms. So a lot being done, and we need to know more and more about long COVID and how long it is going to last.
And just to say, if you think about different viruses that we can have that leave us with long-term impairment, and just think about the polio virus, long-term impairment, and now we have vaccination, really helps prevent that. But there's also other conditions that viruses cause, whether it's SARS-CoV-2 or a different one, that we end up down the road as we do research and follow the science, we can develop therapies for those things.
That's right.
And what we have to hope is that for some of these longer-term conditions, we're going to get this to be better.
Well, before we go to the next question, I want to highlight what you said, Dr. Stites, in terms of the medical countermeasures. So as we look at preparing for any future pandemic, the United States did a fantastic job developing medical countermeasures to COVID-19 with our safe and effective vaccines, boosters, and updates, and with treatments like Paxlovid. We need to make sure that we get the communication right about the safety and effectiveness of these treatments.
Yeah, I think sometimes in all the political infighting that occurs, we forget that the rapidity of the development of the vaccine is a modern medical miracle.
That's correct.
And has been monumental in helping control this with over 13 billion doses given worldwide. Highly effective, highly safe, and impressive science.
That's exactly right. It was an amazing science to use the mRNA vaccines. Of course, there was decades of research to be able to get to the point where those new and innovative vaccines could be made, and further work being done with mRNA vaccines. But we have to work on the public health messaging so that people understand the safety and effectiveness of the vaccines.
Yeah, it's always remarkable to me that people think the messenger RNA vaccines are brand new. They are not brand new at all.
That's correct.
In fact, they're pretty darn old, and because the science around them has developed over decades. The other thing just to note, and I want to just follow up on one thing you mentioned, public health. We've said that term public health a lot. One of the things we have to figure out from the pandemic is how are we going to improve public health in the United States? Because we were vulnerable in ways we didn't need to be because we have gutted public health spending in our
Well, you're exactly correct. We really need to invest in our public health system at the local, state, and federal levels. And the CDC is working on doing exactly that. And we need to make sure that they get the long-term sustainable funding to be able to do that at again, all different levels.
To help us react and be ready and be prepared for things like this.
Exactly
Okay,
right.
Jess. Sorry. Personal soapbox.
So that's okay. And this is kind of similar to that last question. Becky says, just with how awful some of these stories are, we know that a lot of these long COVID folks can't work. So, Admiral, are they considered disabled? Should they be considered disabled in some of these severe cases?
Well, that's a complicated question because the word disabled means many different things. If they're having chronic symptoms so that they can't work, there might be, depending upon their disability policy, ways that they can get funding to help them while they can't work. It's completely different if you are totally disabled through Social Security Administration. And so actually it gets complicated from a legal perspective. But we have been working with the Social Security Administration, with the Department of Labor, to try to sort that out in terms of the different levels of disability, to try to, again, develop the supports and services that people need.
I mean, so much of it depends on, when you look at disability and how you achieve it, or not achieve it, but have to be on it, is the degree of the disability, not necessarily the cause of the disability.
That's right.
It's a lot of it has to do with how disabled are you from any single disease. Jess.
So the last question is from Trudy. Does insurance, including Medicare, cover long COVID?
Well, insurance should cover long COVID. Of course, through the federal government, we have CMS, the Center for Medicare and Medicaid Services, and so they involve different criteria for Medicare. They set certain standards for Medicaid, but Medicaid is run by the states, and then we have the marketplace in terms of the Affordable Care Act insurance. So yes, there are insurance codes for long COVID. For people who have Medicaid, it might depend upon what your state has done. For people with commercial insurance, private insurance through their employer, it'll depend what their insurance company is doing. But we have set up diagnosis codes to reimburse medical providers for treatment for long COVID, and we're continuing to work on that.
Jess, I think, was that the last question I understand?
It is. I'll let you get
All
some
right.
final thoughts.
Well, Admiral, it has been an absolute honor to have you on our program today. Thank you for being here, and thank you for helping update us all on long COVID. We'd like to have our guests have some final thoughts today. Parting comments that you might have for us today.
Thank you very much, Dr. Stites. It was such a pleasure to be here today at KU, to be with you, Dr. Stites, and to be on this program to talk about something which is very important, and that is long COVID. The take-home message is that long COVID is real. People are having very severe symptoms, and we heard from that from the patients, the young women that were on the show today. And the federal government is responding through research and through developing supports and services to help people with this very serious condition.
Hawk.
Yeah, no, I think that's right. I think we need to focus on prevention. We've talked so much about prevention here on the show, whether it's getting your normal screenings, getting your other vaccines, to be up to date with vaccines. Just as the Admiral said, we know things can help prevent the risk of getting long COVID. That includes being up to date with vaccines, also getting tested early and getting on Paxlovid early. The data continues to support the fact that those things help reduce your risk of long COVID, and that is vitally important moving forward. So again, thank you, Admiral, for being here, and I just wanted to continue to piggyback on those points you made. In fact, there was a new publication, New England Journal of Medicine, just overnight that showed that the vaccines also, there is no increased risk of stroke or cardiovascular events. And so I know people continue to have fear or anxiety about getting the vaccines, but they are safe. They've been given so much around the world, and they can also help reduce your risk of getting long COVID.
Yeah, it's interesting to me. People keep trying to find ways the vaccines aren't safe, and I'm like, what battle are you trying to fight?
Yes.
What is the angst you feel from something that those of us in the scientific aspect of this say, God, this is incredibly safe? But you know, that's part of the story of this program since its inception. We're not going to flapjack with the truth. We're just going to try and be honest and tell you what it is, not flap our arms and scream about stuff. Instead, what we'll try and do is give you reliable information. And Admiral, we really appreciate your being on here today to give us reliable information and to stress once again the importance in the partnership between science, which can deliver new cures for cancer, can deliver new cures for cystic fibrosis and other diseases, and also help us deal with the impacts of COVID-19. And we look forward to the impact science has on trying to help us manage long COVID. Science, the health of the public, faith, hope, science is what we say in this program. That combination is the most powerful of medicines. All right, so Jess, you told me before the update that you might have some final thoughts yourself.
I do. Yes, our team wanted to honor you, Dr. Stites, Dr. Hawkinson, the Admiral, and all physicians today who keep us healthy. Today is National Doctors Day, so some of our grateful patients wanted to share some thanks along with us. You at home can also send more recognitions to your doctors by scanning the QR code on your screen.
Unit 61, the doctors, the care, everything, it didn't just save my life, it saved my family's life.
They are an amazing team. I could not have made this through without them and all that they did and all that they sacrificed.
A huge thank you, first of all. And not just for the obvious of saving my life, but the way that everybody communicates. I understand they're all very scientific, but they're all just, I found them to be great communicators.
Dr. Hoffman, I love when I meet with him. This is a good staff here. You know, they make you feel like you're at home, you know. It's like, kind of like family. You become family.
And he said, don't worry, I do this every day. I don't want you to worry, you're going to be fine. When I heard that, I said, boy, Dr. Mubach's for me. He's the best.
And it is Thursday. Alexa Stelzid is here with a preview of today's new episode of All Things Heart. Hey, good morning.
Jess, good morning. We have a fascinating episode for you. Undergoing one organ transplant is a huge deal, right? You're about to meet a patient who underwent 2 organ transplants at the same time.
Because I was, too stubborn to die.
All right, so he is self-admittedly a stubborn man. However, having 2 brilliant teams of doctors and nurses and medical staff caring for him certainly didn't hurt at all, right? So coming up at 10 a.m. in just a little bit, you're going to meet Carlos, our patient, and you're going to meet just a few of the doctors who played a huge role in saving his life with 2 organ transplants, a heart and a kidney. So bring your questions. It's going to be a great program.
Alexis, thank you so much. We'll be watching. And thanks to everyone for watching our program today. We will see you back here tomorrow. Coming up tomorrow on the Morning Medical Update. Crippling pain so bad, one cancer patient says he would simply lay down on the floor and cry. I'm Jessica Lovell on the next Morning Medical Update. The 8-year journey from diagnosis to remission, plus the ugly gap in access Black patients can face. Friday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.